Hello and welcome back to the Academy of Anaesthesia. I hope you're not bored with vomiting just yet, because we've got one last video about the clinical applications of everything we've talked about so far. We've finished the physiology of vomiting and the pharmacology of antiemetics in parts 1 and 2. Today we'll be going over the risk factors, the predictive models in adults and children, as well as the management strategies to manage both low and high risk patients. This video is aimed at the Final FRCA, but you could be asked parts of it in the Primary FRCA clinical questions, so let's get right into it. First, tackling the risk factors. Anytime you get asked about risk factors for anything, use a categorisation method. The one I use is dividing the risk factors into patient factors, anaesthetic factors and surgical factors. For post-op nausea and vomiting, patient factors include being less than 50 years old, being female, being a non-smoker, having a history of post-op nausea and vomiting, or motion sickness, having a family history of post-op nausea and vomiting, and if you're in paediatrics, being more than 3 is a risk factor. Interestingly, prolonged or excessive dehydration, for example if a patient who doesn't follow the correct fasting instructions, is also a known risk factor for post-op nausea and vomiting, and is one of the reasons behind the sit-till-send protocols that have recently been introduced. Some disproven risk factors are BMI and anxiety. Moving on to anaesthetic risk factors, these include having a general anaesthetic, using volatile anaesthetic agents, the use of long-acting opioids, using nitrous oxide as part of the gas mixture, hypotension perioperatively, uncontrolled pain postoperatively, and the use of neostigmine. Surgical risk factors include the duration of surgery, the type of surgery, with certain procedures such as gynae, urological, ENT, GI and neurosurgical surgeries being of the highest risk. Swallowing blood is also a strong emetogenic stimulus, and so any surgery which causes bleeding into the airway will increase the risk of post-op nausea and vomiting. Laparoscopic surgery, especially with reverse Trendelenburg position, and strabismus surgery are highly associated with post-op nausea and vomiting as well. These are the main risk factors to remember. There are certain scoring systems which encompass the most important risk factors. The two most important ones you need to know for the exam are the Apfel Score and the POVOC Score for children. Apfel scoring is well known and fairly intuitive to use. The Apfel Score has 4 risk factors: being female, being a non-smoker, having a history of post-op nausea and vomiting or motion sickness, and using long-acting opioids. Each give you 1 point. You can translate the points into the risk of post-op nausea and vomiting. For example, having 0 risk factors is equal to 10% risk, 1 point is equal to 20% risk, 2 points is equal to 40% risk, 3 points is equal to 60% risk, and a maximum of 4 points gives you a risk of 80%. The POVOC score, on the other hand, is an abbreviation of the phrase post-operative vomiting in children. It's used in paediatrics and gives you a point for ages more than 3, duration of surgery more than 30 minutes, a history of post-operative nausea and vomiting or a family history of post-operative nausea and vomiting, and specifically strabismus surgery because of how emetogenic it is. The translation of the score to the percentage isn't as intuitive as the Apfel score, but the core principle of the more risk factors, the higher the risk, is still maintained. Just to compare, it's 9% for 0 risk factors, 10% for 1 risk factor, 30% for 2 risk factors, 50% for 3 risk factors, and a maximum of 70% from 4 risk factors. The risk percentages I've quoted here aren't exactly the same as published values, but they're close enough and are a compromise at making it easier to remember. You're not expected to know the exact values in the exam. Let's use a case study to talk about the strategy. Consider Mary. Mary has been listed for middle ear surgery, and she's 30 years old, she doesn't smoke, and she's otherwise ASA1. She has a history of post-operative nausea and vomiting and motion sickness, and in her last operation, she tells you she was violently sick afterwards. Even though it's a day case, she had to stay in for a night in the hospital. For any complication or risk, the strategy I like to use is to, number 1, identify the modifiable risk factors in your patient. Number 2, modify the anaesthetic technique and the surgical technique to mitigate those risk factors. Number 3, consider the remaining non-modifiable risk factors and stratify the patients into low, medium or high risk. Number 4, give the primary prophylactic treatment according to that low, medium or high risk. And number 5, give any secondary prophylaxis if the risk or complication occurs. This strategy can be applied to any type of risk, for example the risk of post-operative infection or the risk of perioperative complications, so it's very useful to have in mind. We've already discussed the risk factors that contribute to nausea and vomiting above, and so going through them and identifying which of those your patient has and which of them are modifiable is step 1. In Mary, these would be the fact that she's female, less than 50, she's a non-smoker, and she's got a history of post-operative nausea and vomiting. You also anticipate that the procedure is going to be painful, and so you'll need some post-operative opioids for analgesia. Therefore, she scores fully on the Apfel score, but she also has additional risk factors, namely the type of surgery, which will be ENT surgery, and more specifically middle ear surgery, where the surgeons request a slightly lower blood pressure to help with the visualization of the surgical field, and so permissive hypotension may be necessary during some parts of this procedure. It's also not a procedure that can be done via regional anaesthesia, and so a general anaesthetic will be required. Apart from Mary being a non-smoker, there aren't that many patient risk factors that we can modify. There are some anaesthetic and surgical risk factors, and so we'll have to optimise our anaesthetic and surgical technique to mitigate the risk. And moving on to step 2, to modify the risk factors in Mary, we can divide our anaesthetic technique into the preoperative, intraoperative and postoperative strategies. Preoperatively, we can ensure she's been adequately hydrated and not excessively dehydrated. Asking her to start smoking would be silly because of the high risk of other complications, and so this can be completely disregarded. You might even consider placing her first on the list if it's a day case procedure, so we've given plenty of time for the post-operative nausea and vomiting to settle before discharging her. Intraoperatively, we can slightly alter our anaesthetic technique. Rather than using volatile anaesthetic agents, we can use total intravenous anaesthesia as our maintenance method. This fact is too deep for the exam, but for a bit of context, a systematic review and a meta-analysis showed that propofol-based TIVA maintenance anaesthesia reduced the relative risk of post-operative nausea and vomiting by 39% compared to inhalational anaesthesia, and so it is one of the most powerful alternatives we have in our arsenal of skills to counter the risk of post-operative nausea and vomiting. Avoiding the usage of nitrous oxide is already precluded by the fact that this is middle ear surgery. Running IV fluids to maintain that hydration intraoperatively is also sensible. A Cochrane review has shown that giving 30 ml per kg was more beneficial than 10 ml per kg at reducing the risk of both early and late post-operative nausea and vomiting, and so being liberal with fluids seems to be the better option here. We can use a multimodal analgesic regimen post-operatively to avoid having to give high doses of opioids. If the surgical field needs optimizing, we can use other strategies that are common to neurosurgical anesthesia, such as optimizing the ventilation and the venous drainage before considering permissive hypotension. If we're going to induce hypotension to help the surgeon's field of view, we can keep it to a minimum, i.e. for as short as possible and only as much hypotension as is necessary. Something else you can consider is having an experienced ENT consultant as the primary operator, and it may reduce the duration of the procedure and the need for excessive hypotension for prolonged periods of time. Lastly, middle ear surgery usually means having to monitor the facial nerve that runs close by, and so if you've given a muscle relaxant to intubate and it hasn't worn off before the surgeons calibrate their nerve monitor, then we can give Sugamidex instead of neostigmine. Post-operatively, there's little we can do at this point, but continuing to ensure adequate hydration and maintaining a multimodal strategy for analgesia can help reduce the risk of any post-operative nausea and vomiting from developing. The other thing to consider here are any enhanced recovery pathways that may be relevant to the procedure. So with this comprehensive anaesthetic strategy, we've modified the risk factors that are modifiable. And now it's time to move on to step 3, which is to stratify her risk with the non-modifiable risk factors that remain. She's still a female, non-smoking young adult undergoing high-risk surgery with a strong history of post-operative nausea and vomiting, and so she still has a very high risk. The 4th consensus guidelines from the International Anaesthesia Research Society, published in 2020, give a very simple method of stratifying risk. If the patient has 1 to 2 risk factors, they're low risk. For more than 2 risk factors, that's considered high risk. And Mary is clearly still high risk. And so for step 4, the recommendations are that if the patient is low risk, you should give 2 prophylactic antiemetics. And if the patient is high risk, you should consider 3 to 4 prophylactic antiemetics. The guideline recommends dexamethasone and ondansetron as one of the most efficacious combination therapies, but others exist and will depend on where you work. For combinations of 3 or more antiemetics, the best combinations haven't been studied well enough to recommend. But one would anticipate that targeting the different receptors that we mentioned in part 1 of this series would be the optimal strategy. An example would be a combination of dexamethasone, ondansetron and cyclizine. That's primary prophylaxis, and now for step 5, which is secondary prophylaxis. And for Mary, we haven't given her anything to target her dopamine D2 receptors, and so if she needs a rescue antiemetic, the choices include metoclopramide, prochlorperazine and droperidol. There's no right answer here, and so using a drug that you're comfortable with would be ideal. The same principles of steps 1 to 5 apply in children, but where it differs from adults is that the guideline stratifies children into 3 categories. Those with 0 risk factors being low risk, those with 1 to 2 risk factors being medium risk, and those with 3 or more being high risk. It recommends 0 or 1 antiemetics for low-risk children, dual combination therapies, specifically dexamethasone and a 5-HT3 antagonist for medium-risk children, and for high-risk children to also include TIVA as part of the anaesthetic strategy. And so with that, we can say we've gone from basic principles all the way to how you can apply this knowledge into your practice. We've covered the main questions related to post-operative nausea and vomiting for both the primary and the final FRCA. Not only that, but we've also delved deep into some of the evidence available. I've linked the 4th consensus guidelines in the description below and any other references should you want to do any further reading. As usual, I hope you found the video useful and thank you very much for watching.